All right, so I have a lot of material to cover, so I think we better get settled in and get started. Um, so the topic is, as you can read, there is current concepts or trends in the treatment of type A aortic dissections. It's an evolving field that is riddled with tons of morbidity and mortality, and that we're always trying to come up with different ideas and techniques to improve on the outcomes. I really don't have any disclosures. So today we'll talk about the classification. We'll touch a little bit on the pathology, etiology, how patients with this type of problem present, the diagnostic modalities, the medical management versus surgical management, and endovascular therapies. Aortic dissections, based on the IRAD data in the U.S., at about 10 to 15 cases per 100,000 adult year patients, which is about 10 to 12,000 new cases a year. 2/3 of patients who present with dissection are type A, and about 1/3 type B. And you also have the acute aortic syndromes, such as the intramural hematoma, the penetrating aortic ulcers, and the ruptured thoracic aneurysms that present acutely as well. Autopsy series have shown that aortic dissections occur in about 0.2%. Males are more likely to have this type of problem or present more frequently than females. Ascending dissections occur commonly in the age range between 50 and 55 years old, and in younger patients if they have connective tissue disorders or pregnancy or the so-called bicuspid aortic valve disease. Descending aortic dissections occur typically in the older population. As you can see, don't know if this has a laser. Yes. Most of the dissections occur at the sinotubular junction, and then thereafter you see them at the level of the brachiocephalic trunk or distal to the left subclavian. Occasionally you'll get some dissection that occur in the infra-abdominal or in the abdominal segment. Dr. Leftriades from Yale, I borrowed this slide from him. He calls this disease the great masquerader, because if you can imagine, you have a dissection that occurs proximally at the sinotubular junction. This can actually cause a rupture, which can then cause tamponade, and the patient presents with cardiogenic shock. It can basically shear off the coronary arteries, and the patient will present with coronary artery or ischemia, or the patient can present with acute heart failure because of the deformation or the geometry of the aortic valve gets deformed with the dissection. The dissection can then also occur in the supraortic trunks. The patient can present with a stroke or ischemic limbs. As the dissection goes down the descending thoracic aorta, it can shear off the intercostal vessels, and therefore the patient can also present with paraplegia or cause malperfusion of the mesenteric vessels as well as the solid organs in the abdomen. And you'll have renal failure, liver failure, or mesenteric ischemia, as well as distal lower extremity ischemia. And so that's why it's such a difficult diagnosis to make. I think one of the earliest descriptions of aortic dissections was done by Frank Nichols, who was the physician to King George II. Apparently, he collapsed while in the commode. He was straining and basically died. And this is the earliest description of an aortic dissection. He describes it as the pericardium was found distended with a quantity of coagulated blood, nearly a pint. The whole heart was so compressed as to prevent any blood contained in the veins from being forced into the auricles, which is the atria. Therefore, the ventricles were found absolutely void of blood, and in the trunk of the aorta, we found a transverse fissure. And I think this is This is one of the cartoon renditions of his autopsy. It was described as transverse in the inner side of the aorta, about an inch and a half long, through which some blood had recently passed under the external coat and formed an elevated ecchymosis. This is the classic description of what a type A dissection is. Moving forward, the first people who described the initial treatment for type A dissection was Dr. Cooley and Dr. DeBakey. They performed one of the first replacements of a dissected aorta using a homograft. Later on, in the mid-60s, Dr. Byron Wheat from Florida first described or proposed the modern pharmacological anti-impulsive therapy to decrease the shear force on the aorta when you have a dissection. And to this day, we follow those recommendations. In 1965, Dr. DeBakey came up with his classification, and later on in the 70s, the Stanford classification was described as well. And in 1975, Dr. Greep and his colleagues first described the use of hypothermic circ arrest to be able to treat these deadly disease. Michael DeBakey actually survived surgery for the treatment of a type A dissection at age 97. The story goes that it was New Year's in 2006, New Year's Eve. He was home alone and experienced severe chest pain. And he deduced that more than likely it was not his coronaries, because he had recently seen his doctor who had checked him out. So he said, I must have a dissection. And, but he didn't do anything about it. His wife and his daughters were gone shopping. When they came back, they found him in the sofa, you know, in really bad shape. They called his colleagues at the Methodist. They came by and they saw him. They wanted to hospitalize him, but he didn't want to be hospitalized. And so it's hard to tell a giant, if you will, you know, what to do. You can't make them do anything. And so they brought nurses and doctors. They put IVs. They started beta blockers and everything. They treated him at home, basically. He did not want to be hospitalized. And so he actually, on that New Year's Eve, he had been preparing for a talk. And he still went and gave his talk while he had the dissection. He was described as ashen and still gave the talk, and even had time. He was a big political buff, had time to chat with a senator that was present at his talk. Eventually, they convinced him to come to the hospital to get a CT scan, and the CT scan confirmed that indeed he had it was a type A dissection. It was a type 2, the Bakey type 2 dissection, which basically, I'll explain that nomenclature, and it measured about 5.4 centimeters of diameter. He still did not want to be hospitalized, went home, and around January 25th, 26th, finally, he agrees to come to the hospital. But yet, he still did not want to have surgery. They repeated the CT scan around February 3rd, and the aneurysmal dilatation was up to 7.5 centimeters. He still said, well, let's wait a few more days and see what happens. And so eventually, he started to lose consciousness, and that's when George Noon, you can see him right here, Dr. Noon, one of his proteges, his trainees and partners, convinced an anesthesiologist, not from the Methodist, because they didn't want to put him to sleep. This anesthesiologist came back from another hospital and did the anesthesia, and the repair was done. And you can see him here postoperatively. He's kind of a happy fellow. Actually, he was happy that they operated on him. He was not very upset. Everybody thought he was going to be upset that they ended up operating on him. But he survived for a couple more years after this repair. So the etiology of this, the pathogenesis is that, as you know, the aorta is composed of the intima, the media, and the adventitial layers. The dissections usually occur at the level of the media. And you can see a pathological specimen of an aorta that's been dissected or that had a dissection. The false lumen is compressing the true lumen of the vessel. And you can imagine if you have, this can completely be compressed, and then you don't have any more flow downstream. So why do these type of pathology occur in the aorta at specific spots? And these engineers did a study using finite element stress analysis. It's a type of analysis that they do, for instance, in bridges to determine where do they need to reinforce these structures so that they don't collapse. Or for instance, in a tire, a tire in your car, what area in that tire has the highest shear stress so that they can rebuff it. Does anybody know where the highest stress on a tire is? The walls? I'll give you a choice. The walls, the actual part that's contact with the road, or the bead around the rim?
Bead around the rim.
Actually, if you cut a tire transversely, you will see that the bead around the rim is like it's a whole bunch of metal. It's almost like a cord that surrounds the that surrounds the rim, and that's where the highest stress is on those tires. So it is. You can imagine at a speed of 75 miles per hour or 80, if you're me, and you get a flat, you need to have. That's more that the chances where the problem will occur. It's not going to be in the bead because that's extra reinforced. At any rate, so these researchers found out that the highest shear stress in the aortas is at the sinotubular junction, as mentioned here, as seen here, the brachiocephalic trunk, and the left subclavian, which is typically where you see these dissections occur. So this is Dr. DeBakey's classification. Type 1 dissection starts from the root of the aorta, goes across the arch, and it goes all the way down to the bifurcation. A type 2 dissection, which is what Dr. DeBakey had, is consigned basically to the ascending aorta and usually ends prior to the take of the brachiocephalic trunk. A type 3B starts distal to the subclavian, and type 3A, type 3B, and then it ends in the mid-descending thoracic aorta or the distal descending thoracic aorta, and type 3B goes all the way down to the bifurcation. Further classification based on the Stanford classification basically is that they simplify things in terms of for the management purposes of this disease. They describe the type A dissection as starting in the ascending aorta being involved, and type B specifically is the ascending aorta is not involved. And so this sort of made easier the surgical treatment and less clutter to be able to define how to proceed with these patients. The duration from clinical onset will tell you the acuity of the disease. If it's within the first 14 days, it's called an acute dissection. Between 14 days and 3 months, it's a subacute dissection, and chronic is greater than 3 months. The predisposing factors for a aortic dissection is, as we mentioned, advanced age. Mean age is about 63. This is again from the IRAD data. Males it occurs more frequently in males. There's a history of hypertension. A known history of aneurysm disease, is about 16% of the time that it'll occur. Marfan's patients, based on the IRAD data, they were also more prone to dissection, as well as the bicuspid aortic valves. Those patients with bicuspid aortic valves tend to have a connective tissue deficiency in the ascending aorta, so they're more prone to developing aneurysms and dissections as well. About 2% of the time during cardiac catheterizations, they will cause a dissection. Prior cardiac surgery, and in the peripartum period, they can also occur because of the hypertension that happens. The typical presenting symptoms in 464 patients, as reported by Hagen, basically all of these patients will have pain, some kind of pain. It can be either back pain, chest pain, and it varies the area where you'll have the pain. If the dissection involves the mesenteric vessels, they'll come in with an acute abdomen, for example. The pertinent physical findings, most of the time these patients are hypertensive. They can sometimes present with normal blood pressure. If they're hypotensive or in shock, beware, because these are the patients that are about to die on you, and you got to rush them to the operating room right away. They probably have either ischemic failure or they're in tamponade. Aortic insufficiency, they can have up to 12% of the time. They might have a deficit in the pulses, strokes, or being congestive heart failure because of the aortic valve insufficiency that they can develop. X-ray findings, this is for purely historical purposes. We really don't use it as much, but sometimes if you see a widened mediastinum in a patient in the emergency room present with chest pain, think dissection, okay? Because a lot of people have missed it, and they thought that the patient was having an MI, and so then they start TPA or whatever that they use, and then they just make the problem worse. If they have displacement of the intimal calcium on the chest X-ray, also be cognizant of that as well. That may potentially represent a dissection. The main modalities for diagnosis are as seen here. MRI tends to be more sensitive and specific than a CT scan. However, as you know, the MRI is a couple of hours at least in the MRI scan. You don't want to send a patient with a dissection to the MRI scanner. So we typically rely on CT scan, which has pretty decent sensitivity and specificity as well. TEE also is very good. However, it's more invasive. You can, for instance, if you suspect a dissection and they send you a patient with a CT scan that's non-contrast, and you suspect the dissection is there in the operating room, it's very easy to put a TEE and be able to see if indeed there is a type A dissection. The most important factor leading to the correct diagnosis is the high index of suspicion. So in a type A dissection, the entry tear, as I mentioned, can occur at the sinotubular junction. And so what happens is that the blood can extravasate and actually cause cardiac compressive shock, or they can deform the aortic valve because the commissures are sheared off from the wall, okay, causing the valve not to coap adequately, and so then you have significant regurg leading to acute congestive heart failure. It's a surgical emergency. Every hour that you wait increases the mortality by 1%. 48 hours is a 50% mortality. These are the results of type A dissection repair based on some of the IRAD data, and as well as the Japanese data. You can see that you can have a mortality up to 26%, and or between 10 to 26%. If you do have malperfusion, the mortality increases from between 30.5 to 30.5 with malperfusion versus 6.2% with no malperfusion. Coronary artery involvement, the mortality can be as high as 20%, and cerebral malperfusion is about 67%. If the patient is not operating within 5 hours of the onset. There is a paper by the Safi group in Houston who basically all comers, they will take them to the operating room as quickly as possible, even if they're comatose. And they reported an 86% full recovery on these patients. So the construct of the surgical repair is basically you want to stabilize the aortic root. You do this by resuspending the aortic valve or replacing it. You need to, if the dissection involves a coronary ostium, you have to somehow be able to piece it together, or just basically have to perform a Bentall operation, and I'll go into a little bit of detail on that. You replace the ascending aorta. Traditionally, in the old days, we just repaired that ascending part, which you just needed to do whatever was possible to get the patient off the table. However, nowadays we actually do a little bit more than just repair the ascending. We actually do a hemiarch repair under hypothermic circ arrest versus a total arch if the dissection involves the arch and it's complex. The modalities is obviously deep hypothermic circ arrest versus moderate hypothermia with selective antegrade cerebral perfusion versus retrograde through perfusion, and I will talk about that as well. So this is a picture of a dissected aorta, and here is the actual repair. Here's the cartoon of what this should look like, from the sinotubular junction to the, you make an oblique transection of the aorta from the brachiocephalic trunk to the lesser curvature, sort of almost opposite to the takeoff of the left subclavian to excise as much of the diseased tissue as possible. Here is a slide of a root that has been preserved with bioglue and also sutures, just reapproximating the two layers that have been dissected. The commissures have already been resuspended. The distal anastomosis is reinforced by a sandwich technique. If you know, that's one way of doing it before you do the distal anastomosis. Or you can do a Bentall procedure, which involves basically replacing the whole root complex and reimplanting the coronary buttons onto a, this is a Valsalva graft, probably a graft that has a valve in it, a valved conduit. In order to understand some of the concepts of, or the newer concepts on the treatment of these dissections, you have to sort of go back to the history of the so-called elephant trunk technique. Prior to the description of this technique by Dr. Borst from Hanover, Germany, the mortality for any arch work or any arch pathology was so high. And he basically revolutionized the way aortic surgery was done in the arch by coming up with this technique, which involved opening the aorta, and this is one of his original drawings, and putting a graft into the aneurysm, suturing the graft to aortic tissue here. So that was one anastomosis. He then would come in and suture another graft onto that suture line that had a keyhole to reimplant the supraortic trunks. He would then bring that graft and anastomose it onto the sinotubular junction. As you can imagine, you're doing 2, 3, 4 anastomoses under hypothermic circ arrest, so you have to be super fast. Otherwise, you know, you're going to have neurologic problems. You would then later on, so this was a 2-stage procedure. You would later on bring the patient to the operating room through a posterolateral thoracotomy, open the aneurysm, clamp the graft or do it under circ arrest, and then anastomose it to the artery or bring another graft. Initially, his technique wasn't really accepted at that time. Stanley Crawford was very active in Houston, was doing a lot of this aortic work, and he basically didn't think it was really going to work or pan out. But it's interesting that he had one of his proteges or trainees, Lars Svensson, actually work on it to try to improve on Dr. Borst's technique. And so he came up with the evagination technique. So basically he evaginated a tube graft, dropped it into the aneurysm, and sewed that on the distal aorta, and then he would then pull that segment out, create a keyhole, reanastomose here. So he basically cut back on the one anastomosis and also the circ arrest time for these patients. So that was another key technique that he developed to revolutionize how aortic arch pathology is done now. So that's what the elephant trunk basically means, is you basically are leaving, it looks like an elephant trunk. You know, it's a graft that's free floating in an aneurysmal sac. So then the Japanese back in 2002, and actually had been working on it, they had been working on it in the late 1990s, are the ones who came up with this frozen elephant trunk technique. And initially they didn't call it a frozen elephant trunk. They were basically doing a ascending hemiarch repair, and then to tack the flap on the proximal descending thoracic aorta, they would then put an endostent. And then they went to Dr. Boris and told him about this technique, and he's the one who coined the phrase frozen elephant trunk. And the reason why it's frozen is because not so much that it's cold or frozen, it's just that it's fixated, it's frozen in place, it's not floating like you see in a traditional proximal descending thoracic aortic aneurysm. So this is how the frozen elephant trunk technique is performed. You basically excise all the diseased aortic tissue. You perform a hemiarch resection. You put a wire down the open aorta, and then you basically deploy a stent antegrade, landing it just distal to the takeoff of the left subclavian artery. You then come back and you do your actual repair. And by doing this maneuver, you basically have taken care of the proximal descending thoracic aorta and also the distal arch. So this is the first case that I wanted to present to you guys. A 56-year-old woman presented with acute onset back pain. She was a known hypertensive, was on the treadmill at the time of her symptoms. She was on hydrochlorothiazide and ACE inhibitors. No known history of cardiac or aortic disease in the family, and she was hypertensive on presentation. This is her CT scan. You can see that there clearly is a type A dissection. It goes across the arch and down the descending thoracic aorta. It's a complex dissection. You see several tears in the ascending aorta. For these patients, I always like to get as central access as possible. And so at this time, this is one of my first patients that I did in Portland, Oregon. I was taught to always get axillary access or brachiocephalic trunk access. However, in dissection, especially when the dissection involves a brachiocephalic trunk, you don't want to mess with that. So I basically made an incision at the deltoid pectoral groove, got out the axillary artery, put an 8mm Dacron graft onto it, and then connected it to the bypass circuit. This gives you the ability to be able to perfuse the brain once you put a little clamp here in the brachiocephalic trunk while you're under circ arrest. You're still perfusing the brain. And then that gives you a little bit of more time to take to be able to do your reconstruction. This is the sort of the scheme of how we do this. This is the cardiopulmonary bypass circuit. Blood is taken out of the right side of the heart, and also this says the left atrium. It actually should be the LV. You have the blood goes into the oxygenator, then oxygenated blood then comes back into the axillary artery. When you have the aorta, this is after you cool the patient and you stop the machine, you're only flowing to the brain. You put a clamp in the brachiocephalic trunk, you're going to be perfusing the brain in this direction. We also wide this arterial conduit and put a perfusion catheter to perfuse the left side of the brain. In these patients, you don't have the time to see if there's a complete circle of Willis or not. And so I always put a catheter and perfuse the left side of the brain as well while I'm doing my repairs. And that gives me time to either do an extended hemiarch or a total arch if I have to. So here in this lady, basically what I'm doing, this is what she had. She had the commissures had completely were a volts. That's the valve commissures off of the aortic wall. And so we do commissuroplasties, basically as pledgeted U-stitches from the inside out to resuspend the valve. In this case here, I'm doing the resuspension, putting my commissuroplasty sutures. I then put interrupted sutures around the vessel, bringing the two layers together, and then I use bioglue to glue the pieces together. And this gives you a nice, sturdy reinforced aortic segment onto which you're going to sew your graft. Some people would do a sandwich repair. They would put a Teflon, or not a Teflon, but a felt strip inside and out, like I showed in the earlier slides, and then that way they reinforce that. I was basically taught by Dr. Caselli to do this technique. I think this is quicker You don't have the felt in your way when you're doing your anastomosis. You can be very precise with the placement of your sutures. Following the procedure, once you're done with your proximal, you hooked up your tube graft onto the root, you then prep the distal area. So just to orient you, here is the venous cannula. Okay, the head is over here, heart's here. The graft has already been anastomosed to the root of the aorta. We have now resected the diseased aorta down to the level of the brachiocephalic trunk is coming off right somewhere around here. Okay, and we are now prepping things to do our frozen elephant trunk. A wire is passed down the open aortic segment through the true lumen. You need to make sure it's in the true lumen, after which you follow it with an endostent. This is a Gore endostent. You can see the end of the endostent here, the proximal end, which is the tip, is over here. This is typically a 10-centimeter stent. You advance it, and you're directly looking at the takeoff of the subclavian artery so that you land the stent just distal to the subclavian artery, as shown in that cartoon that I showed earlier. And this is the device. It's a large stent that is mounted on this delivery device. Typically, these stents, we bring them retrograde through the groin to treat proximal, or to treat thoracic aortic aneurysms. But in this case, we're using it backwards, without fluoro, and basically we're just using our eyes to be able to line it up correctly. This is the stent has already been deployed. You can see the cannula perfused in the left carotid artery. Here's the edge of the stent there. You want to fix the stent to the aorta. Usually bird's beaks a little bit, and so you can just put a pledgeted U-stitch to fix the stent in place. And once you've done that, then you can complete your proximal anastomosis. Again, the root is here. It's been already reconstructed. You bring the tube graft to form your hemiarch. This is the 3-month post-op CT scan of that same patient. You can see really nice apposition of the dissected aorta. You can see in some segments that there is residual dissection in the more distal segment, but you've accomplished the goal of at least causing remodeling of this segment so that this doesn't continue to grow. And also, if you ever have to intervene in this part of the aorta, if this was dissected, you would have to go all the way, pretty high. But now that this is remodeled nicely, you can just do a more distal repair, which is less risky. I don't know if I'm running out of time. So this is how we do it. In order to pick the correct size stent, you want to get measurements at 3 different views. I always get a measurement in the axial views, right at the takeoff of the subclavian artery. I also get a sagittal measurement to determine the size of the stent, is wall to wall, and also in coronal segments. And I always oversize 10 centimeters, and then picking the stent. I place these arrows on this CT scan of this patient that this is the patient that we treated here. We don't want to have a narrow focus and just concentrate on the ACE and the aorta. It's important to pay attention to the other parts of the arteries. In this case, you can see partial occlusion of the carotid artery. So it's something you want to keep in mind and fix them if you feel that they're occluded and whatnot. And we've done that here, where we've actually done a carotid bypass simultaneously, as well as a type A repair. Let's see, get a movie to work. So this is the CT scan of this patient post-op, and the ACE repair has been done. You can see the frozen elephant trunk here. You can still see residual of the false lumen, but eventually, with time, at about the 1-year mark, you hope that you will see a remodeling of the vessel. This is a 3D reconstruction of that frozen elephant trunk. Again, we have this. This is early. you got to give it some time for the remodeling to occur. And if it doesn't, then it's very simple to go back in here and put another endostent and come more distally. So why a frozen elephant trunk? It does add a little bit more to the time that you're circ arrested. It may even add some morbidity and mortality. The reason is this, is that if you don't do a frozen elephant trunk, then you end up with this type of scenario. This is a 65-year-old gentleman who underwent a type A repair in Stanford. A lot of complications within the hospital for months. Notice that the aorta at the level of the arch is very dilated. And in the descending segment is also, nothing really has happened here. This patient is going to need to have another operation to be able to take care of that problem. And you can imagine if you would have taken care of that problem at the onset, you wouldn't have to deal with this type of situation. This is the angiogram prior to the repair. As you can see, it's a complex aortic arch. And specifically, this is the patient that actually drove me to go back to training. This guy was a redo chest. I was a vascular surgeon at Kaiser South, and I took him on and never done a redo reentry before. Those of you who, in the cardiac surgery side know that those are very complex things to do. And some people say that ignorance is bliss, and so, luckily I didn't kill the guy, and I ended up debranching him. But the whole time I was just like, pardon my French, shitting bricks, because there's no bypass standing by. It's just me and Jack Cashton. I'm sure some of you guys know him. And so Rich Florio was also there, and it turns out a big success. The guy ended up going home, but then I started thinking, if I'm going to continue to do these cases, if I want to do these cases, I need to go back to training. I was not married at the time, didn't have any kids, and so I decided to leave my practice and go back to school. And I was lucky that I got accepted at the Texas Heart Baylor program where Dr. Caselli and Denton Cooley were the actual program directors. So there's been a lot of literature on the use of the frozen elephant trunk technique, and it showed pretty positive results. This is a meta-analysis, 17 studies analyzed, and the pool mortality was 8.3%, pretty acceptable. Their stroke rate was about 4.9%. And spinal cord injuries, however, was a little bit high, 5.1%. The 5-year survival was between 63 and 88%. And the summary is that these are pretty acceptable morbidity and mortality in these patients that are very complex to begin with, but it really doesn't take that much time to perform the technique. This is more data comparing the old elephant trunk technique to the frozen elephant trunk technique. And basically, as you can see, the mortality is less with the frozen elephant trunk technique than the open repair or two-stage technique. However, there is a higher risk of spinal cord ischemia with the with the frozen elephant trunk technique. And I think this has to do with the size of your endostent that you're putting in the descending thoracic aorta, and also the fact that these are dissections. As you imagine, you shear the intercostal vessels with a dissection, so they're higher risk for paraplegia. And endoleaks, well, you don't get endoleaks with an open repair because you don't have any endostents. And really, this is a misnomer. They're not really endoleaks. There's just continued false lumen perfusion. And in these cases, you have to basically extend to treat the aorta. Again, you may have to go back and do another intervention. And again, there is no such thing as endoleaks in these frozen elephant trunks. It's basically just false lumen is still patent, and so their radiologists will call it an endoleak. Spinal cord ischemia, again, is related to the amount of intercostal coverage. Stent graft and kinking, I really have not seen it, and I've been doing this now for 5.5 years. Coarctation is also something that I've not seen. So the indications for the frozen elephant trunk technique is for aneurysmal disease. It's more definitive treatment of these aortas. You basically replace the ascending aorta. You then also fix the arch and then take care of the descending thoracic aorta by advancing your endostent and sealing here. And obviously for the acute type A dissections, it's a modality that I think is going to improve the outcomes and decrease the reintervention rate on these patients. So again, with the frozen elephant trunk technique, you avoid further distal surgery. There's no interim mortality, as it was with those patients that first got the arch done, then you took them back to the operating room and did a second operation to put either a stent or tack into that elephant trunk. With this technique, you can do it all in one shot. In a type A dissection, you get more reliable thrombosis of the false lumen when you do this technique. So the people who have the most experience with this technique is the Germans in Hanover with the Dr. Bohr's group. And you can see here that describing what happens at different intervals when you follow these patients. Initially, like the patient that I showed earlier, you still see the false lumen. And it's not up until the 1 year mark or 2 year mark that you get actually complete remodeling of the descending thoracic aorta. This is their outcomes based on the type of hybrid graft that they used. This is their own one that they made, and the Thoraflex and the Joe Evita stent. This is the freedom from distal aortic operation for each prosthesis. 10-year follow-up, and it doesn't look like they followed the other ones as long as they did their own endograft. Their outcomes for in the Evita open registry, 274 patients, their mortality was 15%, stroke was 6%, and spinal cord ischemia, again, it's still 8%. But you can imagine this looks more than 10 centimeters. Again, Dr. Bors, in his initial description of the elephant trunk technique, described leaving only a 10 centimeter segment of graft down the descending thoracic aorta. Because if you left it longer, then you occluded more intercostals, and that's where the spinal cord ischemia happens. So I'm not super surprised that they had such a higher spinal cord ischemia. The other thing is, I also, in this paper, I didn't really see how far did they cool the patients. They didn't describe that either. So the newer concepts that I think that we need to start trying to accept is even though the total arch replacement is associated with a higher morbidity and mortality compared to just the hemi-arch repair or even the ascending repair, you need to start thinking ahead that, in order to avoid having to re-intervene in those redo arches, because they're redo operations, they're higher risks, that it's not that much more difficult to actually replace the arch with these newer techniques, and I'll show you how. Take, for instance, this patient has a dissection, and presumably, although this is a cartoon, if you can imagine, the dissection actually is in the arch itself. Replacing this arch down to the level of the subclavian artery. The subclavian artery, as you know, is very posterior. It's very difficult to get to. And not only that, but you're also going to be sewing a graft into diseased dissected aorta. But what if you basically ligate it here, and instead of going all the way down posteriorly to the level of the subclavian artery, you transected the aorta, did your anastomosis here. You're still sewing the crappy tissue, pardon my French, but you can bring your frozen elephant trunk and actually straddle your anastomosis. Basically, you're protecting the anastomosis. You bring it into your endograft, and then all you have to do is reimplant your supraortic trunks. At a later time, you can do a carotid subclavian bypass if the patient needs it. What we're doing more and more nowadays, we're actually just occluding the subclavian. It doesn't make sense to increase the morbidity of going way posterior, injuring the recurrent laryngeal nerve or the vagus nerve as it crosses in this area. And so I think that nowadays we're a little bit more more cavalier, I guess, with these techniques. We're able to take care of the whole arch. In this cartoon, we started doing this here as well, where we actually cover intentionally the vessels. For instance, we can cover the subclavian or even the carotid. We then, while we have not performed, before performing the anastomosis, we actually burn a hole in the graft, thereby creating a fenestration, and then just bridge it with an endostent. You're treating the arch. You're basically are eliminating the false lumen, and you still are able to inline perfuse your supraortic trunks. So the remaining problems with aortic surgery, again, is a stroke rate. We want to minimize the bypass time. There are some people who still continue to do deep hypothermic circle arrest. They'll cool the patient down to 16 or 18 degrees. I tend to be more of a moderate hypothermic type of a surgeon. I only cool to 26 degrees, but that's because I perfuse the brain with selective antegrade cerebral perfusion. We flood the field with CO2 so that we can diminish the amount of air that collects in the ventricles. And then more recently, I started doing retrograde cerebral perfusion. So one of the advantages of having this circuit here is that once you've done your distal anastomosis, you can then take this perfusion catheter, stick it into the superior vena cava, stop flow here, stop flow if you're perfusing from the bottom as well, and then put a clamp right here, and then just flow retrograde, flushing all the air and whatever debris went into the brain. You do that at about 300 to 500 cc's for about 2 minutes. And I think that there really is no data. I don't really think there's anybody doing this just as a temporary retrograde cerebral perfusion. And we shall see how our results come up, because stroke is one of the Achilles heels of this operation. In terms of paraplegia, we want to reperfuse the lower body as quickly as possible, and that's why now I also perfuse both through the axilla and also through the lower extremities, because I want to make sure that we're perfusing the spinal cord via the hypogastrics. We're also perfusing the solid organs so that we decrease the amount of acute liver failure or renal failure as well. The length of the frozen elephant trunk, we try to keep it to approximately 10 centimeters. If we are going all the way across the arch, then we will put a longer stent, maybe a 15, or if we go to the left carotid, or if we go beyond the brachiocephalic trunk, then I would put even a 20 centimeters length stent, because this arch will eat up at least 5 to 10 centimeters of length. Let's see, I think I covered all that stuff. So here at UC Davis, again, the type A dissections are considered surgical emergencies. If there is no major stroke, we take the patient to the operating room right away. If there has been a stroke, we then manage them medically, just like Dr. Wheat described, with antipulsive therapy and blood pressure management. And we wait for the symptoms to plateau or improve, and that can take from days to weeks to months. These patients sort of self-select themselves to do well. Again, if you don't fix a type A dissection at 48 hours, it's a 50% mortality. If they do well, then more than likely they're going to do fine when you do operate on them. Whenever possible, we try to remove as much of the dissected tissue as possible, and we perform a hemiarch with all of our type A dissections, and when the arch is involved, we will do a total arch with the frozen elephant trunk. This is our data, or at least from what I gleaned so far, and since I've been here, in 1.5 years, we've done 34 type A dissections. I think there was a few stragglers that, because of the way the nurses named them, but actually I think the numbers between 34 and 37. 22 of them were done with the frozen elephant trunk. All 4 of the cardiac surgeons are now doing them that way. We've had 4 deaths. That's an 11.7% mortality, which is pretty similar to what the IRAD data and what everybody else is doing. 2 of those deaths were due to acute liver failure. They came in hypotensive and in shock to begin with. You put them on the bypass machine, and that's going to potentially make things worse. We've had 2 of them died from strokes, and we had a total of 4 strokes, 2 of them fully recovered. One particular individual was here for months. The family did not want to take him off. They just basically felt that he was going to recover. He was trach and he was pegged. He was from India visiting, and so because the family didn't want to take him off life support or anything like that, basically UC Davis ended up footing the bill to send him back to India. He went back to India, and the report was when he got to India, he actually woke up and started doing fine and did fine. We've had 0 spinal cord complications with this frozen elephant trunk technique. In summary, we talked about the etiologic factors, we talked about the classification and anatomical considerations. We stated that the type A dissections is an emergency operation. We do a hemi-arch and plus or minus a treatment of the total arch, and with both of them, we try to put a frozen elephant trunk to reinforce our anastomosis, our distal anastomosis. The open endostenting with the branching of the mid-arch is an emergent technique because we can now are able to do a sutureless anastomosis to the subclavian or to the left carotid, and that expedites the construct of those anastomoses so that you are able to flow to the brain quicker. And so that's up in the future. We've been doing them here, and we will continue. And I'd like to thank you guys. This is my residents. We graduated. This is the final graduates from Dr. Cooley's tenure as the residency director at Texas Heart. 2 years later, after we graduated, his wife died, and then a couple of months later, he died. And he was present at all the labs. He was always there to give us pearls and talk to us. Whenever we did the simulation labs, he was very, very much into working with the residents. Did not operate anymore, but he showed up to work every single day. This is Dr. Joe Caselli. I spent a lot of time with him in the operating room and learned a lot of things from him. Thank you. I'll entertain any questions you guys have.
Victor, that's great, and I really think you show the benefit of this combination training in both vascular and cardiac, and so the extra just tools that are in your toolbox to think about solving some of these problems, like dealing with the carotid, which would probably not have been an initial response right away for someone just traditionally trained. So, Nihilus and I have been talking about this for a long time about whether having some kind of joint training program, really would change the shape of how people think about these problems. But particularly in that proximal aorta, it's clear that really is a huge advantage. So we feel very special about having. We've got a minute or two for some questions over here from your colleagues. Let's go with Lisa first, and then the boss.
Okay. Question for you. Great talk, great history. Refreshed a lot of fond memories from WashU. Do you have comparisons between other papers comparing just a standard tube graft versus the frozen elephant trunk technique for just straight up ascending type A dissection?
The only data is what I showed. It was Escobedo, I believe, and the frozen elephant trunk technique actually showed that there was a decrease in the mortality when you do it in the one-step technique because you're basically are not going. You're not debranching, basically, and you're not sewing into diseased aortic tissue. The problem was that their spinal cord ischemia was worst in that data. And again, I suspect that has to do probably with the length of their frozen elephant trunk that they use. And also, from reading that paper, I didn't really see how much they cooled the patient. I think one of the reasons why we were able to decrease that risk is we cool the patients. That protects the spinal cord from ischemia as well. But these patients are very complex. They sheared off their intercostal vessels. They're a higher risk for paraplegia than the average individual that does not have a dissection.
Yes. Victor, great review. Thanks, and thanks for bringing your quite unique skill set to UC Davis. There are a lot of cardiac surgeons that still do some vascular surgery, but I don't know any of them that have the skill set when you combine all the peripheral vascular techniques along with the ability to manage the central vasculature. Our question is, the contemporary holy grail is the endograft management of the entire aorta, including the acutely dissected ascending aorta. That's been quite elusive over the past decade, as you know, with many, I would say, aborted attempts to do open surgery altogether and just manage the ascending aorta acutely with an endograft. What are your thoughts about where we are with that course?
I think we're very close. I think that, you know, with the branched endografts are not going to work in dissections. You know, you don't have the space to be able to treat that aorta with the endovascular approach. And the Achilles heel of that is that their stroke rate is above 10%. But I think that with a laser fenestration technique, we can actually deal with these problems. And I've actually been thinking about it. I've been having these discussions with one of our vascular colleagues, or one of the vascular residents. And as you know, if you can identify the dissection as happening in the arch, we can bring an endostent and cover the whole arch down into the into the ascending aorta. We can then do laser fenestration of the supraaortic trunks and reestablish flow to the brain. The problem is when the valve is detached from the commissures, and I think that in that setting, the TAVR technology would help us to stabilize that problem by using, for instance, the core valve, which has that extra stent that fixes itself to the ascending aorta. And so I don't think it'll be long before somebody starts treating the dissections this way. Now, if the coronaries are involved, then you have to do an open repair, obviously. But you know, if the coronaries are not involved and all you have is just aortic insufficiency, the dilation of the ascending aorta is not that big, then there are some endovascular techniques that can be done to fix that problem. And I think that as we do more and more laser fenestration, is going to prepare us to be able to deal with that if it ever comes to fruition. Yeah.
Pretty amazing. Right. Well, thank you very much. Really.
You're welcome.